Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we'll be dealing with the management of endometriosis, right? So in the last module, we discussed about endometriosis, what is endometriosis and in which group of female it occurs most commonly and what are the most common locations this endometriosis can happen, what are the theories of endometriosis and the symptoms, right? In this module, we'll be discussing about the management part. So before discussing that, it is very important for me to tell that management always consists of investigations as well as treatment. Be it a university examination or any examination, if a question has been asked like management of endometriosis, it doesn't mean that you need to write only the treatment. It means that you need to write both the investigations as well as the treatment. So management always includes investigations as well as treatment. Is that clear? Okay, so now let's start with the topic. So we all know that the chief complaints of endometriosis can broadly be classified into two types. One is going to be pain and the other is going to be infertility. Now under pain, what will come? The secondary dysmenorrhea with the female experiences during her periods, followed by chronic pelvic pain and then pain during intercourse with her partner, that is dyspareunia. So all these are pain, right? So this comes under the heading of pain complex. So one is going to be pain and the other is going to be infertility, right? Excellent. Now, so if the patient comes to me with this complaint such as secondary dysmenorrhea, chronic pelvic pain radiating to the lower abdomen and the thighs, and the patient complains of infertility, dyspareunia, so the patient came to me with such complaints. Now, as a doctor, I need to perform some examination in her in order to elucidate certain signs, right? So as soon as the female comes to me, I need to, what am I supposed to do? I have to do a per abdominal as well as per vaginal examination. As far as gynecology is concerned, you have to do per abdominal as well as per vaginal examination. So on per abdominal examination in endometriosis, you will be able to find nothing. So it is going to be normal. So when you do the per vaginal examination, what you will be able to elucidate? See, the normal position of the uterus is what? Normally, the uterus is going to be in a position of anteversion. Now, what is anteversion? Anteversion means the uterus is actually facing towards the cervix. So it is anterior in location. The uterus is curved towards the cervix, right? That is anteversion. But in case of endometriosis, the position of the uterus is going to be retroverted. Now, what do you mean by retroverted? So instead of anteverted, in the opposite direction, it is going to be in a state of retroversion. And what is the reason for this retroversion? We all know this endometrial tissue, which is supposed to be present in the uterine cavity, is present ectopically at other sites, the most common being the ovary. Since it is present at other ectopic site, this active endometrial cells can actually get adhered or attached to the surrounding pelvic structures. So as it gets attached to the surrounding pelvic structure, it is going to remain like an attachment, right? It is going to stick to that. So because of that pull, the uterus is going to change its position from anteversion to retroversion, and since it is attached like a glue, it is going to be fixed retroverted. What do you mean by fixed retroverted? That it can't be manually corrected. When you try to correct the retroversion, it can't be corrected manually. So the uterus is going to be in a state of fixed retroversion. So in any clinical scenario, a patient with complaints of dysmenorrhea, dyspareunia, chronic pelvic pain, on examination, fixed retroverted uterus, and if the endometriosis is going to occur in the ovary, which is termed as endometrioma, if it occurs in the ovary, or chocolate cyst, in that cases, definitely when you do the per vaginal examination, while palpating the adnexa, you can feel an adnexal mass, and when you palpate, the patient will wince with pain. So that is termed as adnexal tenderness, right? So any clinical scenario with hints such as dyspareunia, chronic pelvic pain, dyspareunia, patient with complaints of infertility, on examination, fixed retroverted uterus which can't be manually corrected, and adnexal tenderness, this points towards endometriosis. Is that clear? Okay. So with this alone, we can't proceed with the management. So definitely we need to look for some other things, and that has to be some investigations. Is that right? Yes. So what is the first investigation you are going to do in a patient with endometriosis? The first investigation in gynecology, in most of the cases, it is going to be transvaginal sonography, that is ultrasound. You are going to order an ultrasound, transvaginal sonography, where the ultrasound probe is going to pass through the vagina. So transvaginally, you are going to do the ultrasound. Now, is this ultrasound the investigation of choice for endometriosis? No. Ultrasound is not the investigation of choice for endometriosis, but it is the first investigation in a case of endometriosis. Then, despite being not an investigation of choice for endometriosis, why this ultrasound is done as the first investigation? It is because of the fact that when you do ultrasound, you can actually rule out any coexisting disease being present in that female. That is, when you do an ultrasonography, you can see whether the uterus is normal, how is the endometrial thickness, is the endometrium has any smooth muscle tumor that is fibroid, or the endometrium has grown inside the myometrium, which is termed as adenomyosis. Is there any coexisting disease being present in her, so that I may change my differential towards another thing also, I may include another differential in my mind. So is there any coexisting disease, or only this is a case of endometriosis? So in order to rule out the coexisting disease being present in that female, I have to order transvaginal sonography. Apart from that, this transvaginal sonography is also done in order to check whether any chocolate cyst has been present in that female or not. Now, what is this chocolate cyst? As we have discussed earlier, if endometriosis occurs in the ovary, right? If endometriosis is going to occur in the ovary, it is termed as what? Yes, it is termed as endometrioma. What do you mean by oma? Oma means ovary. Endometrioma means endometrium in the ovary. So endometrial tissue is present in the ovary. So since this endometrial tissue which is present in the ovary is going to be hormonally active, every month during the menstrual cycle, the female is going to menstruate from that ectopic endometrial tissue, right? What is menstruation? This endometrium is going to shed off, that is menstruation. If this endometrium is going to be present at any other abnormal location, despite that fact, it is hormonally active. Since it is hormonally active, when there is progesterone withdrawal, then definitely menstruation is going to happen from that ectopic endometrial tissue. So from this endometrial tissue, menstrual blood is going to come. So this blood, since it has no other passage, it is going to get collected in the ovary itself. So if this is going to be the ovary, the menstrual blood will collect in the ovary itself. So as the days passes, this ovary is going to get embedded with this menstrual blood. So since it is getting stagnated with this menstrual blood, it is going to increase in size, right? So when you do this, so this ovary gets filled with this menstrual blood. So as it is going to remain for a long period of time, it is going to have a color such as brownish tarry fluid, blackish brownish tarry colored fluid. Since it is going to be brownish tarry colored fluid, which is similar in appearance to chocolate, we all know that chocolate has a brownish appearance, right? Certain chocolates have brownish tarry colored appearance, and this chocolate cyst also contains chocolate tarry colored brownish material. So because of that reason, it is also termed as chocolate cyst. Why it is called a cyst? Anything with fluid component is called a cyst. Since it contains the menstrual blood, it is called a cyst. And since that menstrual blood, since it's stagnant over a long period of time, it is going to be brownish tarry colored fluid. So because of the dark tarry colored fluid appearance, it is termed as chocolate cyst. So when you do the transvaginal sonography, and when you see the ovary, in transvaginal sonography, you may be able to see some cyst. As shown in this transvaginal sonography, this is a chocolate cyst. So a chocolate cyst is identified in a transvaginal sonography. It may be identified or it may not be identified as well. Is that clear? Okay. So why am I saying this is a chocolate cyst? It is because, as you can see here, it has a very homogeneous appearance. What do you mean by homogeneous? It is very ground glass. It is very clear, right? It is going to be even in appearance. Is that clear? It's going to be entirely black. So anything which is going to be homogeneous in appearance, it has homogeneous internal echoes, right? Anything which is going to be homogeneous in appearance is called as ground glass appearance. It is called as ground glass appearance. So only cystic fluid, anything which is cystic in consistency, that is anything which contains fluid, it is going to remain homogeneous in nature. So ground glass appearance, homogeneous internal echoes, it points towards the diagnosis of chocolate cyst being present in the ovary. So as in the ovary, in transvaginal sonography, in the ovary, I am seeing a ground glass appearance with homogeneous internal echoes. This is going to be a chocolate cyst, right? This is going to be a chocolate cyst or endometrioma. Yes, clear, right? So in transvaginal sonography, I may or I may not be able to see this endometrioma, right? Okay. But you also need to remember that let's say for example, you are going to do a transvaginal sonography, and in transvaginal sonography in the ovary you are not able to see any chocolate cyst. So if the chocolate cyst is going to be absent, is the diagnosis of endometriosis going to be ruled out? No. Irrespective of the presence or absence of the chocolate cyst, it has nothing to do with the diagnosis. Even if the chocolate cyst is going to be present or absent, you can't rule out this endometriosis. So absence of this endometrioma will never rule out endometriosis. Is that clear? Yes. So because of the reason that endometriosis not just occurs in the ovary, it can occur in any other sites as well. Yes. So because of that reason, absence of chocolate cyst doesn't rule out endometriosis. Please keep this in mind. Is that clear? Okay. Now, if transvaginal sonography is not the investigation of choice, then what is the investigation of choice? The investigation of choice is laparoscopy. Laparoscopy is the investigation of choice. So let me come back to laparoscopy later. But before that, it is very important for me to let you know what is the ideal treatment of this endometriosis. As we have discussed now, until now we have discussed the first investigation is going to be transvaginal sonography, in which you will be able to rule out any other coexisting disease being present, and then you may or may not be able to see this endometrioma chocolate cyst. And the ideal investigational choice of endometriosis is laparoscopy. So what is laparoscopy? Laparoscopy is nothing but a handheld instrument. Okay, this instrument has a magnifying device. Okay, so through this magnification, you can, when you enter into the abdominal, it has some ports, right? In the patient's abdomen, you're going to make some ports. If this is the umbilicus, you're going to make some ports. So through this port, you're going to actually introduce this instrument, that is laparoscopy. So through this laparoscopy, since it has a magnifying device, through this laparoscopy, you're going to actually visualize in a monitor. So laparoscopy is actually a magnifying instrument which is used to visualize the interior. So if you introduce this inside the abdominal cavity, you can actually visualize whatever contents or whatever pathology is being present in the inside the abdomen through the help of the monitor. So that is laparoscopy. Laparoscopy is done with the help of laparoscope. Laparoscope is the instrument. So as you can see here in this image, this is the laparoscope, right? This has a magnifying device, and this is the laparoscope. And whatever information you are collecting from this laparoscopy is going to be shown in the monitor. So you can monitor it as well, right? Okay. So now, let's discuss about the treatment plan of endometriosis. I will come back to this laparoscopy later, right? Now, treatment plan of endometriosis. As we have all discussed, the main treatment of endometriosis focused on the symptomatic management. What is the symptom? The patient is going to have pain and then infertility. So basically we need to treat this pain and the infertility. So initially, will you treat pain or infertility? First, I have to keep my patient comfort, right? So I need to treat the pain. So pain, which is also termed as secondary dysmenorrhea. So I need to check whether this pain is going to be mild in intensity or it is going to be severe, moderate to severe in intensity. Right? Whether the pain is mild in intensity or it is moderate to severe in intensity. If the pain is going to be mild, what can I do? And if the pain is going to be moderate, what can I do? Let me take a new page and tell you. Okay, so secondary dysmenorrhea. Now I need to ascertain whether this pain is going to be mild in nature or it is going to be moderate to severe in intensity. If this pain is going to be mild in nature, what are the treatment options available to me? And if it is going to be moderate to severe in intensity, what are the treatment options available to me? So if it is going to be mild in nature, what are the treatment options available to me? I need to ascertain, before managing any pain, I have to ascertain whether the patient wants to conceive or not. What do I mean by whether the patient wants to conceive or not? It means whether the patient desires any pregnancy now itself, or is that okay for her to delay her pregnancy by 1 year or 2 years. That is, after this treatment of endometriosis, is that okay for you to have your conception, or now itself you are planning for your conception? If the patient wants to conceive, what is the management you are going to do? And if the patient doesn't want to conceive, what is the management you can do? So ideally, the treatment plans can be like this. See, we all know that the secondary dysmenorrhea is the most prominent complaint of endometriosis. Is that clear? Yes. And the secondary dysmenorrhea happens during menstruation, right? We have discussed in the earlier module that dysmenorrhea happens few weeks before the menstruation, and it persists even after the onset of menstruation. That is termed as secondary dysmenorrhea. Secondary dysmenorrhea happens because of congestive pelvic pathology, the most common being endometriosis. So secondary dysmenorrhea will only happen when there is menstruation in the female. If I'm going to cancel out this menstruation in a female, then definitely the secondary dysmenorrhea cannot happen. So what I have to do, I have to stop the menstrual cycle in that female. How can I stop the menstrual cycle? I can do stop the menstrual cycle through oral contraceptive pills. What do you mean by oral contraceptive pills? Oral contraceptive pills, the main function is going to be that it is going to prevent menstruation from happening in a female. So it is going to delay the ovulation happening in the female. So as it is going to delay the menstruation in a female by administration of estrogen plus progesterone. We all know that progesterone can only act on an estrogen primed uterus. Is that clear? Yes. So when you administer estrogen plus progesterone, this progesterone is going to actually support the endometrium. So once this endometrium is getting support from progesterone, we all know that only when progesterone withdrawal is going to happen, the endometrium will lack its supports and shed out as menstrual blood. Here we know that the endometrium support is provided by the progesterone. Is that right? Endometrial support is mainly provided by the progesterone. Since the levels of progesterone is going to be high in this female, definitely she will never menstruate because the support to the endometrium is provided by this progesterone. So therefore the female won't menstruate at all. So by delaying her menstruation, I can actually prevent secondary dysmenorrhea in that female. Is that right? So the main function, the main primary aim of me is going to stop her menstruation in that female. So this can be done with the help of oral contraceptive pills. So by oral contraceptive pills, I'm going to delay the menstruation in her. Right? So that is the main function of oral contraceptive pills. Not only by orally taking pills also, but there are something called as IUCD Mirena. What do you mean by IUCD Mirena? IUCD is nothing but intrauterine contraceptive device. See, orally, if you take the contraception, it is called as oral contraceptive pills. If you take it through the vaginally, if you get something inserted inside your uterus. So vaginally, you are going to insert something, and that is going to enter the uterus, and that is going to be intrauterine. Since it is inside the uterus, it is intrauterine. Since the effect of this intrauterine device is going to be contraception, it is called as intrauterine contraceptive device, and it is called as Mirena. What is Mirena? It is actually progesterone containing intrauterine contraceptive device is called as Mirena. So the major function of here is that you need to support the endometrium. So once you are going to support the endometrium, the proliferation of the endometrium will never happen, right? So the estrogen will become inactive because the progesterone is going to come into action. So initially the estrogen is going to prime the endometrium, and over the endometrium the progesterone is going to give its support. So since the progesterone is supporting the endometrium, right, the endometrium won't shed off through the menstrual blood. At the same time, the endometrial tissue will shrink, since because of lack of proliferation, only the support of progesterone has been given. The lack of proliferation is present in this female. So only because of this endometrial support, the female will never menstruate. So menstrual cycle is not going to happen in that female because you are giving progesterone. Main function of progesterone is to support the endometrium. And it will also shrink the endometrium. Right, it will support the endometrium and it will shrink the endometrium. This is the major role, that why are you giving oral contraceptive pills and intrauterine contraceptive device to a female with endometriosis. The major function is that one thing, you have to prevent the pain from happening. This pain happens because the menstruation is happening in her. If you are going to prevent the menstruation from happening in that female, then no pain will occur. So therefore I'm going to give contraception either through oral contraceptive pills, or I'm going to insert per vaginally inside the uterus. So the major effect is going to be, it is going to prevent menstruation from happening. So if the menstruation is going to be prevented, then therefore no pain will be experienced by the female. And apart from that, it will also shrink the endometrium. This ectopic endometrial tissue has been responsible for everything, right? So if you're going to shrink this endometrium with the administration of progesterone, since the major function of progesterone is to support the endometrium and not proliferate the endometrium, progesterone will actually support the endometrium and therefore shrink the endometrium. Is that clear? Yes. So one management could be oral contraceptive pills and the other could be Mirena, which is intrauterine contraceptive device. Right? Okay. Now here, this oral contraceptive pills can be either estrogen plus progesterone or only progesterone. So you can give either estrogen plus progesterone or you can give only progesterone. The main function it is going to be, it is going to shrink the endometrium and it is going to support the endometrium. Is that clear? Yes. Now, what are the other options being available to you? The other option is that GnRH. We all know that GnRH is a gonadotropic releasing hormone. We know that there are two types of GnRH. One is going to be pulsatile and one is going to be continuous. We all know that in puberty we have discussed that when you give the GnRH in a pulsatile manner, because of that high frequency LH will be released, because of low frequency FSH will be released. This will happen only if you give the GnRH in a pulsatile manner. But what do you mean by pulsality? Pulsality means you will, let me show you here. See, there is going to be a high, there is going to be a dip, there is going to be a high, there is going to be a dip. This is called as a pulsality. We all know the pulse, right? So this is going to be the pulsality. But if you administer this GnRH in a continuous fashion, so if you're going to administer GnRH in a continuous manner instead of pulsatile manner, this continuous GnRH has an antagonistic effect. So since it is an antagonistic effect, this GnRH, since it is releasing in a continuous manner instead of pulsatile manner, it will never cause release of FSH and LH from the anterior pituitary. So if it never releases FSH and LH from anterior pituitary, FSH and LH never acts on the ovary and it will never release estrogen and progesterone. So estrogen and progesterone, if it is not present, then therefore menstruation is not going to happen. Is that clear? Everyone are clear with this? Only if this hormone, only if the ovary releases the estrogen, progesterone, only if FSH and LH is released from the anterior pituitary, the whole process of menstruation is going to happen. If I'm going to give this GnRH in a continuous fashion, it is going to have some antagonistic effect. So because of this antagonistic effect, FSH and LH will never be released from the anterior pituitary, and because of that, the estrogen and progesterone will never be released. So you can give either oral contraceptive pills or intrauterine contraceptive device, or you can give continuous GnRH, or you may also give GnRH antagonist. Either give directly GnRH antagonist or give GnRH agonist in a continuous manner. Everything is same, right? Okay. So these are the most important management plans in endometriosis. Now, you tell me, all the three management, we have discussed about oral contraceptive pills, we have discussed about intrauterine contraceptive device, we have discussed about GnRH agonist in a continuous manner, which is going to have an antagonistic effect, or GnRH antagonist. Right? So we have discussed about all these conditions. Is that clear? Yes. Now you tell me one thing, that what is the similar feature between all these four things? The similar feature between all these things is that all these things are going to delay the menstruation. Menstruation is never going to happen in the female if you give these four things. right? Because this prevents the menstruation. If menstruation is prevented, therefore definitely in the menstrual cycle only ovulation is going to happen. Therefore on day 14 of the menstrual cycle, ovulation will never happen. If ovulation is never happening, then fertilization will never happen. Therefore the patient will never have any pregnancy. So if the female wants to conceive, if the patient wants to conceive, if the patient desires pregnancy now itself, you can't go with this option, because if you go with this option, definitely there is going to be no ovulation, no menstruation, no fertilization is going to happen in her. So definitely the patient will never have pregnancy soon. It will take some time later, right? So because of that reason, if the patient want to conceive now, you can't give this treatment option. So what is the treatment option you are going to give to her? So in such patients who want to conceive now, the only treatment option available to us is painkiller. You can give her painkiller. And what is the painkiller? We know NSAIDs. Non-steroidal anti-inflammatory drugs are the painkillers. So if the patient want to conceive now, you have to give only NSAIDs. If the patient doesn't desire pregnancy now, you can very well go with this oral contraceptive pills, intrauterine contraceptive device, GnRH agonist in a continuous fashion, and GnRH antagonist. Right? What are the GnRH antagonists? We know cetrorelix, abarelix, etc. elagolix. These are the GnRH antagonists. Cetrorelix, elagolix. So these are the GnRH antagonists. So once these are the treatment options being available for a female with mild or minimal pain. But if the pain is going to be severe in nature, what is the treatment plan? So for mild, let me draw here so that you may understand. Mild pain, you give two options. Patient wants to conceive, NSAIDs, right? Patient doesn't want to conceive, 4 options. Oral contraceptive pills, IUCD, Mirena, GnRH agonist in a continuous fashion, GnRH antagonist. Right? So now tell me, of these 4 things, which is going to be the most effective? The most effective is going to be GnRH agonist in a continuous fashion or GnRH antagonist, because we know that with this oral contraceptive pills and IUCD, the failure rate may be present, right? It may be present in some fraction at least, right? The female might forget to take any oral contraceptive pills on certain days, or and there could be some failure with the misplacement. The thread might get displaced, or the intrauterine contraceptive device can get displaced, right? So because of that reason, the failure rate can be present with IUCD, Mirena, and oral contraceptive pills. But with this GnRH agonist and in a continuous fashion and GnRH antagonist, these are more effective than the other 2 things. So the most important among these 4 is going to be GnRH agonist in a continuous fashion or GnRH antagonist, since this prevents the release of FSH and LH in the anterior pituitary itself, right? So because of that reason, this is going to be the most effective option. Now this is all about the mild. Now we are going to discuss about if the pain is going to be moderate in intensity or severe in intensity. If the pain is going to be moderate or severe in intensity, what is the treatment you are going to do? So if the pain is going to be severe or moderate, therefore the first medication you are going to give is going to be itself the most effective one. Since it is mild, you can start with either oral contraceptive, IUCDs, and then also you can try with GnRH. But since the pain is going to be very severe here, in this cases you have to start with GnRH agonist initially itself, that is going to be in the continuous fashion, and GnRH antagonist. Is that clear? Yes. So first itself you have to take the best medicine, since the pain is very severe in intensity. So the best is going to be GnRH agonist or GnRH antagonist, right? So these are the treatment plans which we know. So apart from this, what are the other things you can do? The main concept is that our goal is to shrink the endometrium, delay the cycles. So anything which is going to shrink the endometrium or delay the menstruation in that female, you can use that drug very well. So whatever we have discussed until now, these are the ideal treatment plans for management of secondary dysmenorrhea in a female with endometriosis. Is that clear? Apart from that, you can also give some anti-estrogens. Now, what are these anti-estrogens? We all know that estrogen has the function of proliferation of uterine endometrium. So once the endometrium is going to be proliferated, then definitely, therefore, bleeding will happen in a female. So if you are going to give anti-estrogen, which is against the estrogen, therefore, the endometrium will never be proliferated. It will never menstruate. Is that clear? Yes. For that reason, you have to give anti-estrogens. So what are the anti-estrogens? You know, letrozole. What is letrozole? Letrozole is an aromatase inhibitor. What is aromatase inhibitor? We all know that androgens get converted into estrogen with the help of the enzyme aromatase. So if you are going to inhibit this enzyme, then definitely androgen will never get converted into estrogen. So the anti-estrogen is going to be letrozole. And then we also have danazol. But danazol is generally not preferred. It is because of the reason that danazol, the most common side effect of danazol is going to be hirsutism. Because of increase in androgen levels, it is going to cause male pattern hair growth, hirsutism in these females. So because of that reason, danazol is generally not preferred, right? Okay. So now we have discussed that in mild, if the pain is going to be mild, we have oral contraceptive pills, IUCD, GnRH agonist in a continuous fashion, GnRH antagonist. Moderate or severe, the first is going to be the best medicine, that is GnRH agonist in a continuous fashion or GnRH antagonist. And then we have some anti-estrogen as well. But if in case all these medical management is going to fail, now what are you going to do? If all the medical management, whatever I have mentioned now, it is going to be fail. What do you mean by failure? Failure means that even after administering all these things in this female, the patient experiences pain. Pain is still present in the patient. Now, the best management is going to be through the laparoscopy. So do you remember initially I told about laparoscopy? Yes, laparoscopy is the investigation of choice for endometriosis. Similarly, laparoscopy is also the best management of endometriosis. Why? Because is that laparoscopy has the advantage of both diagnostic and therapeutic advantages. Both diagnostic as well as therapeutic advantages. What is diagnostic and therapeutic advantages? Diagnostic means through the help of the laparoscope instrument, you can actually visualize whatever been present inside. So you can actually visualize whether this ectopic endometrial tissue has been implanted at any other sites. So it is diagnostic in nature. Why it is therapeutic? It is therapeutic because through the laparoscope itself, through another port, you can actually surgically excise it, right? So because of the treatment can be done, it is therapeutic in nature. Since it is both diagnostic as well as therapeutic, it is going to be the investigation of choice for endometriosis. So what are the indications for laparoscopy? It is that one thing is going to be for the management of chocolate cyst. As I have discussed earlier, chocolate cyst can never be medically managed. We always keep in mind that the management of chocolate cyst is always surgical management. Chocolate cyst can never be medically managed. So for the management of this chocolate cyst, as well as when there is going to be failure of medical management, that is with the medical management, the pain is not getting settled in a female. So failure of medical management, and for the management of chocolate cyst, the investigation and for just both diagnostic and therapeutic is going to be laparoscopy. Is it clear? Yes. So when you do the diagnostic approach with laparoscopy in endometriosis, what will be you able to see? So let me show in the diagram. Right? Actually, you are visualizing whatever been present here. Now what you are seeing here, this is actually the chocolate cyst. And whatever material you see here, so this is the tarry colored menstrual blood. Right? So this is the tarry colored menstrual blood. So this is the ideal chocolate cyst which you are seeing through the laparoscope. And what are these two things? Two things is that these are the red lesions. These are the red lesions. So red lesions indicate new implanted ectopic endometrial tissue. Whereas this gunshot appearance, powder burn appearance, gunshot appearance means it is an old implanted ectopic endometrium. If it is going to be old, it is going to be white, right? So since it is white in color, it is old implanted endometrial tissue which is ectopically implanted. So this is called as gunshot appearance. And since it is red in color, it is called as red lesion. Is that clear? Okay. Also, in endometriosis, most commonly you can see some peritoneal defect. Peritoneal defect. This peritoneal defect is actually because of the defects in broad ligament, which are the ligamental supports of the uterus. So because of the defects in the broad ligament, it is termed as Allen-Master syndrome. Is that clear? So when you do the laparoscopy, which is diagnostic modality of endometriosis, you can see the chocolate cyst. Apart from that, you can see new lesions which are red lesions, and then you can also see the gunshot appearance. So if you get a gunshot appearance, it is an old lesion. Apart from that, you may also see some peritoneal defect, which you can see the Allen-Master syndrome. In patients with endometriosis, most commonly you can see some peritoneal defect. So this peritoneal defect is basically the defect in the broad ligament. So that is termed as Allen-Master syndrome. Is it clear? Can I show you the diagram once again? So this is going to be the laparoscopic image, and this is the chocolate cyst, and here whatever you see here is the red lesion and the gunshot appearance, which is an old lesion. Is that clear? And peritoneal defect can also be seen in patients with endometriosis, which is nothing but the defects or lacerations in the broad ligament, which is the ligamentous supports of the uterus, which is commonly seen in patients with endometriosis, which is termed as Allen-Master syndrome. Is that clear? Okay. So this is what you'll be able to see when you do the laparoscopy. So in laparoscopy, whatever you can see is chocolate cyst, followed by red lesion, gunshot, and then you can also see some peritoneal defect in patients with endometriosis. Is that clear? Yes, so these are the most common appearance which you can see in laparoscopy. Now, what you can do? The therapeutic management is you can actually fulgurate the implants, right? So wherever you see this ectopic endometrial tissue being implanted, you can actually fulgurate the implants. Also, once you take this implant out, you can send this implant for the histopathological examination. So as I told you earlier, the investigation of choice for endometriosis is laparoscopy. The initial investigation is transvaginal sonography. The investigation of choice is going to be laparoscopy, but always the gold standard investigation, which is the best investigation, is going to be histopathological examination. So once you're going to see through the laparoscope, you can also perform some therapeutic advantages as well. So what are the therapeutic advantages? You can actually fulgurate whatever implants you see, whatever ectopic implants you see inside, you can actually remove that implants. So once you remove that implant, you can send it for histopathological examination. So when you do the histopathological examination in the pathology lab, you can confirm the diagnosis of endometriosis. So always the gold standard investigation of endometriosis is histopathological examination. Is that clear? Okay. So now, what are the therapeutic advantages? The therapeutic advantages are that one is that you can do laparoscopic cystectomy. Laparoscopic cystectomy. So when you can do this laparoscopic cystectomy, is that what is cystectomy? It is all about the chocolate cyst, which is also known as endometrioma. So the management of chocolate cyst or endometrioma depends on whether the patient decides pregnancy or not. If the patient wants to get pregnant, you can't do any surgical management in her. So you have to do only conservative management. Just reassure the patient and do conservative management in her. Because if you are going to do some cystectomy in the ovary, there are chances that you may injure the ovary. So once there is some injury to the ovary, it may affect the follicles which are present in the ovary as well, right? So because of that reason, the patient might not get pregnant soon. So if the patient is going to desire pregnancy, you can't touch the ovary. You have to do only the conservative management and reassure her. If she doesn't desire any pregnancy now, you can do this laparoscopic cystectomy, but that too has some exception. One is that if the patient is asymptomatic or if the patient is symptomatic. If the patient is going to be symptomatic and if the size of the endometrioma is going to be more than 5 centimeter. So always remember, in gynecology, anything if it is going to be more than 5 centimeter, you can manage it, right? So since it is more than 5 centimeter and it is symptomatic, the patient is going to have some symptom. Now it is the actual patient where you can do laparoscopic cystectomy. Laparoscopic cystectomy. But if it is going to be asymptomatic and let's say for example the size is going to be less than 5 centimeter, you can just reassure her and ask her to have some follow-up. So ask her to please come back again and let's do an ultrasound, and we can just follow up with that if you get any symptoms being present. And if an ultrasound, the size of the chocolate cyst gets to be more than 5 centimeter, then we can do laparoscopic cystectomy, right? So the management of chocolate cyst, if the patient wants to conceive, conservative management. The patient doesn't want to conceive, two things: if symptomatic, asymptomatic. Symptomatic more than 5 centimeter, laparoscopic cystectomy. Asymptomatic less than 5 centimeter, just reassure her and give follow-up and ask her to follow up. Always remember, chocolate cyst can't be medically managed, no medical management, because we all know that there is the blood actually collecting in the ovaries. So since the blood is getting collected in the ovary is having an appearance like chocolate. That is why it is called as chocolate cyst. So there is no chance that this cyst will actually get resolved on its own. So the only management you can do is surgical management. That is all about ovarian chocolate cyst in the ovary, that is endometrioma. Apart from that, you also need to remember that the second complaint with which the patient is going to come to you is infertility. So when you take infertility into consideration, you need to check whether this is going to be a mild disease or it is going to be a severe disease. What do you mean by severe disease? Severe disease means because of this endometriosis, that is the ectopic endometrial tissue being implanted at other sites, there is going to be inflammation. So because of this inflammation, there are chances of formation of adhesions inside. So if there is going to be presence of adhesions, if there is going to be presence of chocolate cyst in the ovary, since it is in the ovary, chocolate cyst in the ovary, and if the basic anatomy is going to be disturbed. So these signifies the severe disease. Can you understand? The normal position of the uterus is anteversion, but in patients of endometriosis, it is going to be in a retroverted position. That is going to be fixed retroversion. It can't be manually corrected. The second point is that if there is going to be chocolate cyst that is involving the ovary, and if this, because of this inflammation, endometriosis can also have adhesions being present. So if all these features are present, then it is a severe disease. All these features are absent, it is a mild disease, right? So first you need to differentiate mild and severe disease. If it is going to be a mild disease, you need not worry much about that. Since there is no adhesions, you need not worry much about that. So what you are supposed to do here is that you have to manage them as a case of unexplained infertility. Why unexplained infertility? This is because we all know that there may be some hindrance in the pathway. So that is because of that reason, infertility is the primary complaint in patients with endometriosis. Is that right? Since this because of the chocolate cyst or because of the adhesions being present in the uterine cavity or because of the fixed retroversion, there can be problem with the actual implantation. So you are going to facilitate this implantation by doing intrauterine insemination. So since this endometriosis can also involve the ovary, what are you going to do is that you are going to induce ovulation in this female. So ideally you have to induce the ovulation with the help of the drug clomiphene citrate. So you give clomiphene citrate to the female, you induce the ovulation, and once the ovulation is happening, you have to do intrauterine insemination, right? If after doing this intrauterine insemination also there is going to be the same complaint of infertility, next the best option is going to be in vitro fertilization, where in the laboratory you're going to take the ova, you're going to incubate it with the sperm, and once the zygote is going to be formed, you're going to implant it. Once the blastocyst is going to form, you're going to implant it in the endometrium. That is in vitro fertilization. What is intrauterine insemination? Intrauterine insemination is that you are going to directly inject it inside the uterine cavity. That is intrauterine insemination. Is that clear? Yes. If it is going to be a severe disease, what are you going to do? If it is going to be a severe disease, next the management which have to do is only in vitro fertilization, because we all know that adhesions are going to be present in patients with severe disease. So since these adhesions are present, it can actually hinder the pathway of the implantation. So because of that reason, the ideal management in patients with severe disease is going to be in vitro fertilization. Is that right? Okay. So whatever we have discussed until now is all about the management of endometriosis, right? So I hope that everyone are clear with this management plan as well as the investigations. I hope I have put this everything in a simpler fashion so that you can understand easily, right? If you have any doubt regarding this topic, please write to us, or if you want me to repeat this topic, it is very well for me to repeat it again as well, right? The last portion here is that we all know that gold standard investigation is histopathological examination, where you can see hemosiderin laden macrophages. Why hemosiderin laden macrophages? We all know that it is hemosiderin because the menstruation is happening in such females, right? So because of that reason, it is hemosiderin laden macrophages. Hemosiderin is iron pigments, right? So hemosiderin laden macrophages. And you can also see endometrial glands and endometrial stroma from the ectopic endometrial tissue which you have removed through the laparoscopy. So in that tissue which has been examined in the histopathological examination, you can see endometrial glands and stroma being present along with hemosiderin laden macrophages. So this is all about endometriosis, right? So in case if you have any doubt, please write to us, students. Thank you. Let's meet in another important